Okay, let's go to, after discussing that, everybody should already appreciate that there are three major components on the COVID-19 disease, okay? This is the components that will cause the death or the demise of the patient. Number one is hypoxemia, is very low oxygen, and the pneumonia, and it's caused by what we call the pneumonia in COVID-19. It's not like, it's unlike any other pneumonia. It's not like the regular pneumonia that you get from bacterial infection or any other viruses. It's actually called organizing pneumonia. What is it? It's not, we used to treat, or I'm treating once in a while, what we call BOOP, BOOP. It's bronchiolitis obliterans organizing pneumonia. It's an inflammatory pneumonia and organizing pneumonia in the lungs. And the gold standard for treatment this organizing pneumonia is actually high dose corticosteroid, right? So when you have this, it's better that if you start the corticosteroid, not when it's already too far out. And so that is the rationale for using corticosteroid. So in essence, this disease is a steroid responsive disease. Okay, you just have to apply it at the right time. Okay, the second component is the hyperinflammatory response, which is, everybody knows this, it's a cytokine storm. You know, your immune system goes absolutely nuts, absolutely crazy. And when your immune system goes crazy, it only doesn't kill the offending organism or the offending substance, but it kills you. And then the third one is the hypercoagulable state, which is the formation of blood clot or thrombosis. You know, this will kill you. It gives you all the diseases that's possible: stroke, heart attack, gangrene, you know, things like that. And so these are the three main components that we have to think about when we want to prevent people from getting sick. And then in the outpatient, we can definitely think about this, you know, and treat the patient before they progress. And I'm going to tell you, even in my previous interview, I always tell people I'm very aggressive in approaching this disease, aggressive in a good way. Okay, aggressive. And then as long as you time it, you know, the introduction of the medication, you're not going to go wrong. You are not going to go wrong. Okay. So now we focus on, so you can see that we really need to do prophylaxis and early treatment so that we can prevent the, what do you call this, the progression of the disease. Now, there are different, here in the US, the two major proponents or advocates of early or prophylaxis and early treatment are actually FLCC, which I'm a member of. I'm a provider in FLCC, that is the Frontline COVID Critical Care Alliance, okay? And then there's another group, which is actually the private practitioner in the US, and that is Association of American Physician and Surgeon. And I think the big guy in that organization is Dr. McCullough. Okay, so they created, or we created, different protocol. The FLCC, we have the eye mask for the outpatient, and we have the eye mask for the inpatient. Okay, and then in the Philippines, that was 2 weeks ago, or 2 to 3 weeks ago, I am also a member of the CDC PH, or honorary member, whatever. So we got together and actually formulated an prophylaxis and early treatment protocol for the Philippines. So I'm going to present that to you, and then we will see. The protocol that we formulated for the Philippines is called iProtect, and actually it's for the physician, but it's out in YouTube and everybody should watch it, okay? Okay, so these are all the agents that we use in early treatment and prophylaxis. You guys have to realize that this disease, this is not a single drug disease. This is a multi-drug treatment disease. Okay, there is no magic bullet. There is no silver bullet for this disease. If you are praying for that, then it's not going to get to you, because the virus is very versatile. It's creating a very versatile disease. So you need a very versatile approach. Okay? So it's a multi-drug treatment disease. It cannot be just one. We want to think that we should only have one because it's easier, but it doesn't work that way. Okay? You are talking about the human body, and you're talking about this agent or this virus that is very, very mutable anyway. That's very versatile. Okay. So just to go through this, these are the agents that we use, whether you talk about the mask, the eye mat, the eye mask, the eye protect, one of this or all of them will be included. Okay, so the number one, the center of attraction, we need a good antiviral agent, and that is in the form of ivermectin. I know the challenges that we're facing, not only in the Philippines but also here in America, because ivermectin is like a miracle drug, or it's like too good to be true. And so, like, let's say here in America, if this is completely instituted, or it becomes like a public health initiative, it is going to, Dr. Corey always say, it's going to kneecap the vaccination effort. So you know how much money that is. We're talking about 100 billion, 100 billion, and there are different, or Merck, at least Merck and Pfizer, they are developing also their own medication, early treatment medication, and both of them, if you accept ivermectin as the main thing, then we are talking millions and millions of dollars that this pharmaceutical companies are going to lose. Pfizer is going to lose like 250 million, because that's how much they are spending to develop another, therapeutic agent. Like Merck, 320, 350 million, and that's the loss. Okay, so ivermectin has been around for a long time. It was discovered in 1970 by a Japanese scientist, and that's Tushi Omura. Okay, and then he worked with Merck, and Merck actually developed the medication, and this is the medication that eradicated the river blindness. Okay, the river blindness uh, disease, and in Africa and South America. And then eventually we also found that it's also effective in other parasites, including what do you call this, strongyloides, even the roundworm. It's also used in scabies. It's approved for that use. And then also in the Philippines, I believe you guys, or we use it for the elephantiasis or the filariasis. And so it's approved for as anti-parasitic medication. Here in the US, at least, even if we have also the great divide of using ivermectin, we don't have a problem using it as off label. So I don't have any problem giving it to patient, whether as an early treatment or as prophylaxis. Okay, so the safety, or the safety margin of this medication is very high or very wide. There are only 16 deaths associated with it after more than 3.7 billion already given. Okay, and no major side effects. It's very safe. No side. The most common side effect, at least I also encounter it when I prescribe it, is like a little diarrhea, and it becomes a little worse when you actually have what do you call this, parasite, you know, as a reaction. And that's all. A little headache probably, and all the signs and symptoms that you get from the medication, it they go away within 24 to 48 hours. Okay. We also use antibiotic, doxycycline and Citromax, and basically the doxycycline and Citromax, they have both antiviral action, and then they're both of them are also anti-inflammatory, and then when you use them you kind of prevent also a secondary infection. Okay, I put fluvoxamine there because that's the update that was just it was just included in the update of the FLCC protocol. That is actually an antidepressant. It's an SSRI. And then the action is it's a very good anti-inflammatory and immune modulator. Okay. It reduces the production of cytokine when you use that. Okay, we also use anticoagulants, antiplatelet, and it's very it's expected because of the thrombosis, which is one of the biggest the component of the disease. We use corticosteroid. This is the game changer. So everybody focus on this, okay? Because this is how you're going to prevent patient from progressing and from dying. Okay, so in the outpatient, I use all this agent, methylprednisolone, dexamethasone, and prednisone. But I use in the pulmonary world, in our world as pulmonologists, we use more of methylprednisolone for one reason. It has more penetration on the lung tissue, so the patient respond much better. The dexamethasone, I'm not saying that it's not effective, but I think it's uh, substance or a lesser in terms of the action. The dexamethasone is very long acting, but it became very popular because of the recovery trial. That is the what do you call this, corticosteroid that they tried. So everybody, you know, we have to use dexamethasone. But when I'm dealing with a very sick patient or even in the early stages, I use methylprednisolone. They respond much better. You can also use prednisone, and this is only given orally, the prednisone. And then we use monoclonal antibodies. This is not available in the Philippines, but in my protocol, I use monoclonal antibody under what do you call this, emergency authorization use. And then these are the supplements that we use. And this is basically the common denominator of this. I'm not going to go through everything, but they are all immune booster, you know, immune modulator, and then they are antioxidants, whichever one you look at. But I would like to emphasize the use of vitamin D. I think that the vitamin D should be part of the public message. Everybody should be taking vitamin D because the vitamin D is the most natural immune booster and immune modulator. What do I mean by that? If you have the immune system and having the right and the left arm, the right arm being the bad, and then the left arm, or vice versa, the right arm being the good and left arm being the bad, the vitamin D will actually stimulate the good arm. And so when you stimulate that, you tend not to develop the cytokine storm. I'm going to tell you, in the beginning of the pandemic, all our patients admitted, like in New York, in the hospital, it's like 99.9% of those people who died or who were admitted in the ICU, they were all deficient in vitamin D. And I'm going to tell you, vitamin D is not really a vitamin. I think it's a misnomer calling it vitamin. This vitamin D is a hormone. So what does it mean? It helps everything from head to toe, your brain, your heart, everything, and mostly in the immune system. When it was introduced, we were only talking about vitamin D helping the bone. So now we know that this is something that will help your entire body and will actually maintain health, if you take that. So you're going to need vitamin D for the rest of your life because the body needs that hormone, okay? And then vitamin C is a very powerful antioxidant. It helps to reduce the oxidative stress in the body when somebody is very sick. It's also immune booster. Same thing with the zinc and quercetin. Melatonin, very important. This is actually for sleeping. Um, this is the only supplement or micronutrient, only supplement that will actually protect your your mitochondria. The mitochondria are those little uh, little bodies inside your cell that are responsible for producing energy. So in the long hauler people, there is a mitochondrial dysfunction. But that's a different topic, so we'll leave that alone for now. The virgin coconut oil, we included that because it applies to the Philippines. You have so much of the coconut, and this one is the same way. It's a very powerful antioxidant. It has antiviral activity, and for those people who are not able to eat, it actually like a source of extra calories for these sick people. Okay. Now, I'm going to go through this very quickly. You guys have to get the copy of this protocol. This is the outpatient protocol. It's called IMAS. And as you can see, I is for the ivermectin, M is for methylprednisolone, and then A, that's ascorbic acid, okay? And that is vitamin C. And the S is something else here. And then uh, these are the component of the IMAS: ivermectin, vitamin D3, vitamin C, quercetin, zinc, and melatonin. You can see the doses here, and it's the basic one. When it comes to vitamin D3, I'm going to tell you, in my practice, everybody, they don't leave the office, or they don't sign off, or they don't go home without me prescribing vitamin D. Every single patient, I prescribe vitamin D. And this vitamin D, 1000 to 3000, that's a baby dose for me. I maintain my patient at 5000 units every day. I can go up to 10,000, 50,000, but it depends on what disease I'm trying to treat. So that's that. The vitamin C, the same thing. I mean, this is okay dose up to 1,000, but I treat people with very high dose vitamin C. Depending on the diseases, I give it as an adjunct treatment for cancer, for any infection. I can give as high as 25 grams, 50 grams, 100,000 milligrams, or 100 grams. When in the beginning, when there was no recommendation, this is actually what I use for the patient who are infected with COVID. I give them 3 consecutive doses of high dose vitamin C, and they do very well. Or it could be more than 3 days, but I give them minimum 25 grams IV. In my office, it's a little bit different, or a special situation, because I have the ability to give intravenous medication. It's almost like a hospital setting kind of thing, or an infusion center. Okay, so they have 2 doses here for the ivermectin, which is prevention for the high risk individual, those people who have comorbidities, the older ones. And the usual recommendation is zero point 0.2 milligrams per kilogram. For regular people, that would be between 12, 15, 18 milligrams. Here, they want you to take a first dose on that day, and then the second dose is on the third day or after 48 hours. But For me to simplify it, I just tell them take it 2 consecutive days and then every 2 weeks after that. Okay. And then for the post-COVID exposure, to prevent person from getting sick, I mean, it's exactly the same thing, the recommendation, but I do it a little bit different, 2 consecutive days. And I'm going to tell you, because of the presence of the vaccine, we increase that. Actually, the recommendation, you can go up to 0.4 milligrams per kilo. So if you used to require 12, then you're going to end up taking 24. If you used to require 15, it's going to be, you're going to end up taking 30. Okay. So next, this is when you are, what do you call this? Oh, sorry. This is this to show you that when the recommendation is okay, the only difference is you increase the dose of the ivermectin. In FLCC, the ploxamine was already added. Once you can see that the patient is symptomatic, the patient is infected, positive PCR test, uh, they added the fluvoxamine, which is 50 milligrams twice a day for 10 to 14 days. And if the patient, what I do is I use either zero point 0.3 or zero point 0.4, depending on how bad the, what do you call this, the symptoms are. And you give it that way. And it's up to, you take it every day. You take it daily for 5 days until, or you can extend this after for more than 5 days until the patient recovers. Okay. So as you can see, they are also encouraging you to sanitize your nasopharyngeal area. So in the Philippines, we use with you guys, we use the virgin coconut oil, but you can use this. Okay. The vitamin D has increased to 4,000, which is still lower than what I give on usual or normal circumstances. But the vitamin C, you can increase this to much higher than that, like 2,000 twice a day. The only limitation is depending on what vitamin C you are using, it could be irritating to the gut, or you can have diarrhea, for that. So you take it as high as you can with gut tolerance according to what your belly can tolerate. Okay. So the quercetin increase to twice a day. The zinc is also increased to maximum 100 milligrams once a day. And but you only do this until the patient gets better. You're not gonna take it for a very long time, and you can go down to the usual 20 to 40 milligrams of what do you call this, supplementation once you get better. The melatonin, it increased to double with 10 milligrams. You guys don't take it during the day. Okay, people are asking me, should I take all of them at the same time? No, the melatonin should be at night. It's going to make you sleep much better. Okay. Aspirin, you have to start, and this is to cover the clot formation and thrombosis. Okay. And I'm going to tell you, the thrombosis, the mechanism in COVID is actually very complicated. It has several mechanisms, but for the outpatient, it suffices to say that aspirin will do. And you have to take a full aspirin, full dose, 325 milligrams a day. Unless you're allergic to that, or there's a contraindication like bleeding ulcer or something, then you don't take that. Then we can go to other anti-thrombotic agents. There are also some supplements that you can take to naturally thin the blood. What are they? Vitamin E is one, fish oil is another one, ginkgo is another one, CoQ10 is another one, and then there is another enzyme as the nat kinase. Those are blood thinners, natural blood thinners that you can use in lieu or instead of aspirin if there is a contraindication for aspirin. But if you are going to use one or two, agents, you should have your doctors get involved, especially if you are taking medication or anticoagulants because of other condition, like the cardiac people, cardiac patients, they have, the other anticoagulants like the Plavix, the Eliquis. They are factor 8A inhibitors, or they are on Coumadin and things like that. So they need to be monitored very closely when you are using, ivermectin with those agents. We encourage people to use pulse oximetry because this is more important than monitoring your temperature, because this is the one that will tell us if the patient is becoming hypoxic below. That is already an indication for the patient to go to the hospital, or if the patient cannot go to the hospital, this is the time that I give them the corticosteroid, because that is a signal that the lungs are getting bad or getting worse or getting involved into the immune response, which is the cytokine storm, or the beginning of it. So you want to prevent that from progressing, and you want to prevent the lungs from getting damaged further, because that's the one that will kill the patient, obviously, first. Okay, so ivermectin, this is the computation, but just remember how many, the little formula, 0.2 to 0.4 times per kilogram. And so you don't have to have this, but if you want, then you can download it, go to FLCC and get a copy. Now, this is the Philippines. We formulated this, I think 3 weeks ago. It was 3 weeks ago. Yeah, more than 2 weeks ago at least, and it's out on YouTube. Dr. Homer Lim from the CDCPH was the one who put this out there on YouTube, and it. It is based on the IMASC protocol, and also the protocol which was developed by Dr. McCullough of the Association of American Physician and Surgeons. So it's a combination, and we just added something that, like the virgin coconut oil that you have a lot in the Philippines. So iProtect is ivermectin prophylaxis and outpatient treatment in reducing COVID toll. So we have to do it that way so that people will remember that if you do the early prophylaxis treatment, it protects you. It protects you, okay? Please, this I Protect protocol, you need to involve your docs, because this involved the use of corticosteroid. So the doctors need to be involved, and if the patient sees this, then bring it to the attention of your doc, or probably introduce it to your doctor and discuss what kind of treatment you want to have. Okay, so as you can see, the first one, what I like about the I Protect is because we compartmentalize it, we divided it into different groups. The first one is the immune boosting, immune boosting combination. So basically, these are all the supplements that you can take so that you can boost your immune system. You see, if quercetin is not available, you guys can use the green tea extract, or you can eat lots of onions, garlic, or the sweet potato leaves. I like that, but I cannot get it here in the US, only once in a while when I go to a Filipino store. But otherwise, that is very delicious, and I think you guys can do that. Eat lots of onion and garlic, and you are going to get enough quercetin. But make sure that you eat it every day, okay? And then the virgin coconut oil, and you have to take 1 tablespoon 3 times a day. And then the melatonin you have to get, okay? And then this is just guidelines. You can take as much as you want, or you can, vary or adjust the dose depending on the need of the patient, okay? Okay, the next one is the pre-exposure prophylaxis. So this, again, the high-risk individuals, especially the older people, and then people with comorbidities, even though they are young, but they have existing high-risk condition. The frontliners working in the hospital, directly dealing with the sick people, and even the outpatient. As far as I'm concerned, the frontliner should be shifted to the outpatient, actually, if we just implement or take this initiative to implement this prophylaxis and early treatment. The frontliner should not be the hospital. The frontliner should be the outpatient, people, the doctors in the outpatient. So here we are. The ivermectin is the same, also it's zero point 0.2, but as I said, because of the presence of variants they are more infectious and transmissible, this is already changed. This can be changed from zero point 0.2 to zero point 0.4. But for the pre-exposure prophylaxis, I guess you can also stay at zero point 0.2 per kilo. Okay, so it's the same. And you see here, we did it day 1 and day 2 instead of waiting day 1 and day 3, which is in the FLCC. And then from here, you can use it every 2 weeks. In my case, since I see more patients, I even do it every week. Or probably I would take an extra when I get together with some people I don't know them, or I get together with my friends I haven't seen them in a while, and so I would take before I go, or I take it after I get together with people. Okay, so the same thing, all the supplements that are involved, the same dose. And so, as I said, you can adjust the doses however you want. Okay. And by the way, we just have to be careful in using the quercetin, because sometimes when you take too much of that, it can aggravate hypothyroidism, or it can induce that. So the doctors, you guys have to be particular about that. And but in a disease state, if you increase the dose, it's going to be okay, because the utilization will be high, and then the requirement of the body will be high. So, but once the patient gets better, then you make sure that you taper it down. Okay.